problem, and you subsequently either treat it at your own facility or you need to convey it to the tertiary center. So I hope those of you that are in those categories will take home some of the information. And of course, there's others. I welcome that. Okay, this slide is to remind myself that our country is vast, and for some of the vascular services, few and far between, and some areas, especially for us in the East Coast, there's not much luxury referring to vascular specialists. Therefore, it's pertinent or it's important for those general or the registrars to be able to manage at their own center initially. Okay? Okay. This is one of the cases we had last week, where the patient presented with acute painful hand and was admitted to a different specialty, non-surgical specialty. Patient got hypertension with no other comorbid, and I think it was they were admitted for about 48 hours initially, but as you can see, maybe it's highlighted, there's a bit of discoloration, and patient says that the hands are cold and the pulses are not palpable. This is also to highlight the acuteness of the problem, yes? And the pulses are not palpable, and the patient was then subjected to embolectomy, and he was fine after that. And second one, this is to show you a second patient, while the other one was at grade 1 or grade 2, this one is actually gangrene. This one is from ICU. And as you can see, the etiology is actually a difficult puncture from a different specialty. The two slides initially as an introduction for me to show you that a different, spectrum of the two. While this is actually non-salvageable, whereas the first one is salvageable. Those terms will be important when you assess patient and then convey your information to us. Okay, so the slides are out of the way. So basically what I'm going to talk is about introduction. And when you do your readings, always think about what it is, because for you to recognize a condition, you need to know what it is, i.e. the definition, and why. Why in terms of etiology of it? Because once you know what the etiology is, you know how to treat it. And when you know how to treat it, how many different ways there are, and treatment options, of course. Okay, for those of us at the level where receiving these referrals, the important is, of course, life and limb saving. And the second part is you get your colleagues referring you because of medical legal. Most of my discussion this afternoon is around this article. I think you can either look it up or you can see me afterwards. I will gladly give it to you. It's just a review from New England Journal of Medicine. It's very recent. I think 2014 or 2012. 2012. Okay. When you deal with acute limb ischemia, is of course, like I said earlier, this is a recurring thing. Identify what it is, assess and classify whether it's viable or non-viable. If you can pick up what the etiology of the acute limb ischemia, what are the treatment options, and don't forget complication, either after you've done the reperfusion, the reperfusing of the limb, there is also complication associated with it, plus what is complication if you don't intervene. Okay? Acute limb ischemia is a sudden decrease in limb perfusion that threatens tissue viability. It is an acute event, and usually the patient or the clinician will tell you what the point of pathology is. And you must differentiate between chronic limb ischemia and critical limb ischemia. I wouldn't dwell into the definition. The other good reference guide is if you can look up the TAS2 plus, what they call TAS2 literature. In the literature, TAS2, TASC, it gives you all this definition. Okay, we talk about the sudden acute loss of perfusion. They present with pain, paresthesia, of course, weakness, paralysis, the 6 Ps. And what you look for is the absent pulses. These are important when you assess because it gives you how to classify the grade of ischemia. And of course, start thinking of possible causes. Either it's embolic or it's thrombotic, because between the two. And when you examine, are the pulses symmetrical or asymmetry? Because when it's symmetrically absent, you think that this might be an acute on chronic. And of course, the history of intermittent claudication. When we also talk about acute limb ischemia, there's also whether it's trauma or it's atraumatic, and of course, dissection. This is how I think about acute limb ischemia. Like I said, either traumatic or atraumatic. The traumatic are post trauma, and we won't dwell on it. The atraumatic, okay, this is what I put this up. If you talk about traumatic, there's the mangled extremity score. So I think look it up if the orthopedic colleagues, just to see whether it's viable and non-viable and how mangled the limbs are. And if it's atraumatic, don't forget about venous, because venous can give you acute limb if there's venous hypertension, venous gangrene. Okay. In atraumatic, I thought of it as either, I wouldn't say virgin, but virgin means that it's not been had any treatment before, because as you heard from our previous speaker, in the days of endovascular and all the treatments, they might have a graft, they might have a plasty. So this patient is important for you to ask in their history, has any intervention has been done to that limb before? Or for example, they had plasty of the heart, they puncture the femoral or the brachial, and they present as an acute limb. Okay? When I said there was no history of any previous endovascular treatment, can either embolic, thrombotic, is there any issues of dissection? Also check for proximal aneurysm that causes thrombosis distally, and of course the thrombotic state patient that has been discussed earlier as vasculitis, and ask whether they've got any treatment before. Again, just to illustrate that proximal aneurysm gives you all the thrombus that showers distally, because that might be the first signs that they present or symptoms as trash foot, but they actually have got aneurysm. And so palpate the abdomen. If you're doing your short cases, in the masters, say that to complete, you will examine also the abdomen, make sure you have the proximal aneurysm. Okay? Self-explanatory. Again, those patients that has been previously treated is becoming more common, and then think about graft occlusion, either synthetic or native. And again, I alluded to if they've had any endovascular, because with puncture, they might have damaged that particular vessel. So in your history, you need to allude this and to tell to your tertiary center. Okay, this is examples of some of the devices that they put into the artery. Therefore, they can present later with acute limb ischemia. And this is actually a thoracic. This is stent. But in order to do this, they will need to access the femoral. And therefore, if there's history of any intervention, then that might be a cause why they present with. Again, I won't dwell into venous gangrene. A bit of algorithm for those going in when you revise the acute limb ischemia. First, the history and examination. Okay, then there will be question about this. Initial treatment with intravenous heparin. I'll come back to that. Imaging, to do it, not to do it, when to do it. For you then to classify, but actually you don't actually need imaging to classify viable or non-viable. And then whether it's revascularization, i.e. embolectomy. Don't forget, when it is non-viable, that amputation is still a form of treatment, especially when it is life before limb. Okay. This is the assessment I was telling you earlier. Stages of acute limb ischemia, whether you 1 to 3 to A to B. When you talk to a tertiary center or at your level, you need to tell us so we know what you're describing. Usually when it's when it's 3, it's irreversible, means that there's no motor and usually frank gangrene. And little that you and I can do for that limb, it can make it viable again. So it must be conveyed to the patient. Okay? And the treatment then is actually amputation. Initial management for a patient that presents with acute limb is, of course, resuscitation or whatever that they have. Pharmacological agent, we mentioned about IV heparin. If you think that you cannot save or the time it takes for you to do an embolectomy is more than a couple of hours, which shouldn't be, but if you need to transfer, then I would advise for you to start IV heparin. But if you can bring the patient straight to have an embolectomy, then I would suggest that you do that rather than starting the patient on IV heparin. We'll come back to investigation and, of course, surgical intervention. Okay, the question about imaging, it is whether it is available or not. Available also means whether it's going to delay your treatment. If you have a nice angio, but it takes you 3 hours to get in and get it decipher, then maybe it is better for you to intervene early. Okay, a step back before that, the best, I think, if you have an ultrasound also, just to confirm about the acute limb ischemia, or even the first thing is a Doppler. Okay, once, if it's available, then it shouldn't delay treatment. Okay, in acute limb ischemia. Okay, the viability of the limb, as we talked earlier, if it's grade 1 or grade 2A, there's time for you to investigate, but if it's threatened 3, then of course there's no need for further investigation. 4 is amputation. We talked about the IV heparin. I think the Doppler now has become common and everybody knows how to use it, and most of the unit have got it. So this is, I think, among the most important basic bedside tool that you can have, and you can decipher and tell to your if you're going to do it, as in your unit, or you're going to refer it to a vascular surgeon. The information that you need to get, is it actually acute limb ischemia, like I said, or is it acute or chronic? This information is important because these are the things that I expect that the referral hospital or we can get from the primary hospital. Is it actually ALI? What is the etiology of it? Is it a virgin or versus previously treated? What are the comorbid? If somebody who's post-MI, who's on, just had a TPH infusion, and he's suddenly found to have an acute limb, but there's major concern as opposed to the limb itself. So that has got to take into priority. And thirdly, you need to answer whether the limb is salvageable versus non-salvageable. And this can be assessed with that, the thing I said earlier. And then when it is salvageable, whether it is operable. Okay, again, when say time is of essence, once we get the referral, if it decided to be transferred, it doesn't stop there. So the transfer itself, it is not I say burden, but responsibility for the referring hospital to organize it as such. The referral does not end when it's just accepted. You must make sure that the transfer has been done. You need either whatever transport it is needs to be sorted out. Because we've accepted the case, 3 hours down the line, patient is not there because of other issues, logistic. So I think that the referring hospital needs to take that into account. And again, please remember regarding the general condition of the patient, if it's not fit for transfer, that's where the surgeon and the hospital needs to be the leader in that. And of course, life before limb. The reason I put this up is for you at the local as an expertise, you need to know how to manage it because sometimes the patient are not fit for transfer, for example. And also, now that you've come for these conferences, as I alluded to you earlier, with the map, we need more vascular surgeons. So do come and join us in training to become vascular surgeon. Okay, surgical treatment, Mr. Azam will talk to you later. Remember the patient earlier? So it was the brachial approach, and this is the embolectomy specimen on table after the embolectomy. The pulse came back, and then of course the proximal and distal flow was established, and we closed it back. And it was a long clot actually. This is from the brachial, and that is from the radial. This is from the more proximal. That's the clot. Just something on imaging. Again, this is sometimes a luxury because where you have time, there is just a block there, but there's a good reconstitution. So this is a CT of a lower limb. Okay, let's talk about thrombolysis. Thrombolysis of a thrombus, and there's some contraindication. Okay, you might be asked what are the role of thrombolysis, but these are the absolute contraindication. You got a list there. I won't bore you with going through it. And this is for completeness sake, catheter-directed thrombolysis. It will be mentioned, but again, it depends on expertise because you need to be able to do your angio almost daily, and also because once you put in the thrombolysis, you need also to put in heparin, whether it's available in your center. Okay. Do read up on it as well for your preparation for exam. Okay, just one slide on post-operatively uric perfusion syndrome. Okay, you need to identify the patient at risk. This starts when your patient is presented. If you're with ischemia, you need to have your levels of CK. Okay, and before it occurs, you can help by reducing the risk by rehydrating the patient. And of course, the treatment is symptomatic, fluid, and address the renal complication. Don't forget about compartment syndrome. So when you have re-established flow, most of these patients, especially in the lower limb, you need to do your fasciotomy. Okay, and of course role of mannitol to reduce. Okay, I think the last few slides, the key clinical points. Of course, the definition. You need to know causes, embolus, thrombus, and whether it's virgin or non-virgin artery. Assessment, we talked about it. You need to be able to assess whether it's viable or non-viable. Then there is a good discussion between you and your referral to the tertiary center. This is a contention actually, this statement, catheter-directed thrombolysis, but I would actually save that just for thrombosis rather than acute embolus. And amputation again is a form of treatment. It's not a failure of treatment, it's a form of treatment. Okay. Just a few angios. I just want to show one, I think, before. Okay. In this areas of intervention, don't forget some intervention before can present patient with acute limb. For example, a gentleman present with acute limb on unilateral, but he's actually got a stent distally, the stent has thrombosed off. So in these cases, if you have time for the investigation, embolectomy would probably not help. So you need to talk to your tertiary center because they need to do something to the block stent. Maybe thrombolysis. Again, I think that's about it. Unless I open the floor for any questions.